Female lady, 37 years old, presented to our outpatient clinic, mentioning that she was diagnosed as steroid refractory Crohn's disease and taking biological therapy. She was in agony with severe lower abdominal pain that kept her leaning forward. She mentioned that she was suffering from recurrent attacks of abdominal pain with sometimes loose motions 2 to 3 times per day from 2 years with no definitive diagnosis and received non-specific treatment. Finally, in the last 2 months, she was diagnosed before she came to us. She was diagnosed as Crohn's disease because her labs showed the following. Her fecal calprotectin was 1,400. Her treating physician ordered CT pelvic abdomen, which showed dilated long segments of terminal ileum loop with thickened wall, likely inflammatory. Her colonoscopy was rather normal, no ulceration at the terminal ileum and the whole colon, just congested mucosa in the terminal ileum, and her pathology went back to be edematous mucosa with scanty inflammatory cells. Her treating physician ordered MRE, which showed multiple ileal loops with mural thickening with increased enhancement, likely inflammatory, raising the possibility of Crohn's disease with mesenteric soft tissue mass, likely lymph nodes, associated element of subacute intestinal obstruction. Her treating physician started steroid therapy, but showed no response with increasing abdominal pain. So he shifted her to IV steroids and antibiotic, but her case get back worse and developed vomiting. She came at our clinic. She was severely pain with tenderness over infraumbilical area, and there was mass felt in the same region, and she has clubbing in her finger. We admit her and informed our surgical team that it might be a case of complicated Crohn's disease. Her ER lab showed, surprisingly, hemoglobin 11, TLC normal, platelets within normal, CRB negative, ALT 250, EST 60. So we started to question her diagnosis because of that severe abdominal pain not related to the condition with negative inflammatory markers, normal hemoglobin despite her severe pallor. So we ordered emergency CT pelvic abdomen with angiography, which revealed surprisingly mesenteric mass lesion, which was reported before as a lymph nodes, is a lesion in the mesentery associated with desmoid reaction with traction changing in the mid-ileal loops, causing ileal loop kinking that cause here subacute intestinal obstruction. And this edema in the submucosal area, a mucosal area that reported before as inflammation. There was a major shift in diagnosis of the patient within 24 hours. So the patient becomes so anxious. We're trying to convince her that need emergency surgery. At the end, she was convinced and resected. Here is the mass, and this is dilated loop. Her pathology report went back to be a carcinoid disease with metastatic lymph nodes with all removed. And the patient, after operation, she was convinced that might need even biological therapy after treatment. We try to convince her that it's not Crohn's disease at all. It is a tumor in the intestine which all resected. Thank you. Next presenter will be Dr. Terry Magdi.
Straightforward case. Yeah, diagnosed by the
Terry, you'll be the next speaker. اوكي تاري دكتور تاري مجدي.
Good morning. Thank you, Professor Sirag. Thank you, our dear professors, for the invitation. Our case today is a 66-year-old male. He works as a hospital porter. He has a past history of diabetes and hypertension on vildagliptin and bisoprolol. 1 month before presentation, he had a transient ischemic attack for which aspirin, clopidogrel, and cerebrolysine was prescribed by his neurologist. 1 week later, he presented with generalized maculopapular rash. It was erythematous, and a dermatologist prescribed a short course of steroids and 2 types of antihistamines and described the rash as allergic. 2 weeks later, he came complaining of generalized edema, yellowish skin and sclera, and high-grade fever. He has irrelevant past and family history. On examination, he was conscious yet lethargic and oriented. He had a temperature of 39.5 and a pulse of 95. He had jaundice and pallor, yet no cyanosis. He had resolving erythematous rash and no flapping tremors, but he had bilateral lower limb edema above knee level and few subcentimetric lymph nodes. His abdominal examination revealed hepatomegaly and bilateral shifting dullness in Daltrob's area. His chest examination showed decreased at entry, suggesting pleural effusion and normal cardiac examination. On admission to the hospital, he had a total leukocytic count of 16.7 and a platelet count of 35,000. ALT and AST showed marked increase. ALT was above 5,000, AST 4,600, total bilirubin of 10.3, and albumin of 2.5, and an INR of 1.5. Pen cultures, including acidic samples, were done, and empirical antibiotics were started, and the patient was started on supportive treatment. Pelvic abdominal ultrasound revealed hepatomegaly, splenomegaly, and ascites, and pleural effusion. Portal vein duplex was normal. Viral markers appeared at that time, showing hepatitis A negative, C negative, hepatitis B surface antigen negative, hepatitis B core IgM was positive, CMV IgM was positive, Epstein-Barr virus was equivocal, and at that time, serum creatinine increased to 1.7. During the following 10 days, total leukocytic count improved on supportive treatment, platelet count improved, yet the coagulation profile showed marked derangement, showing an INR of 2.4, increase in PTT, FDPs, and D-dimer. Also, blood chemistry showed marked derangement. Creatinine was raised to 2.6. Total bilirubin increased to 16.1 with a direct of 9.4. Liver enzymes showed gradual improvement. Albumin was 2.6. On follow-up, total bilirubin showed marked increase to 26 with a direct of 13. ALT and AST showed gradual improvement again, and albumin was 2.4. During this period, he had recurrence of the high-grade fever, recurrence of the generalized maculopapular rash all over his body. During that time, we had to put a differential diagnosis. So what differential diagnosis do we put at this time? With fever, rash, and history of acute hepatitis. We had suggestions of acute hepatitis B with cutaneous manifestations, cytomegalovirus, drug-induced liver injury, or maybe other diagnoses. A blood culture at that time revealed enteroconchi sensitive to vancomycin, and he started antibiotics. Steroids were started for suggested drug-induced skin eruption, and antihistamines were suggested by the dermatologists, but we did not give antihistamines for fear of liver derangement. Liver transplantation was discussed at that point. More lab results appeared later on with PCR negative for COVID, PCR negative for CMV, PCR negative for hepatitis B and C. Autoimmune hepatitis markers were negative. CA 19.9 alpha-fetoprotein showed mild increase. Cryoglobulins were negative. The skin biopsy showed lymphocytic infiltrate, and the diagnosis at that time for the skin biopsy was secondary infected lichenoid reaction. So, what's your diagnosis at that point? The patient was diagnosed as DRESS syndrome, drug reaction with eosinophilia and systemic symptoms, which is a rare, potentially life-threatening, drug-induced delayed hypersensitivity reaction, including skin eruption, hematologic abnormalities like eosinophilia, lymphadenopathy, and internal organ involvement. It is characterized by long latency between the drug exposure and the disease onset. It is characterized by expansion of activated T lymphocytes causing the drug reaction. In our patient, he had fever, he had enlarged lymph nodes, he had abnormal liver function tests, he had renal impairment, had pleural effusion, and he had eosinophilia on the CBC as shown.
دكتورة تاري الوقت بتاعك خلص. You can go to the conclusion.
Okay. To conclude, our patient during hospital admission, all suspected medications were stopped. He was started on prednisolone and Ticavir, and was started on Celcept for drug-induced liver skin eruption. Steroids were tapered gradually afterwards. All laboratory markers and liver functions and enzymes are now back to normal levels. Currently, the patient stopped all medications, and he is well and fine. This is the management of DRESS syndrome, and thank you so much.
Thank you very much, Dr. Terry. Who will be the next speaker?
Next speaker, Dr. Ahmed Mansour.
دكتور أحمد منصور تفضل. بس هي تبقى difficult شوية. هو الغريب إنها كل static mainly بس تأليف. We don't have enough time for discussion الحقيقة. Maybe at the end we may allow 1 or 2 questions. تفضل دكتور أحمد منصور.
Thank you, Mr. Chairman, and special thanks to our Professor Dr. Srag. Our case today about 38-year-old female patient that presented to our ER. Her condition started 2 years ago when she developed non-bloody diarrhea, 3 motions per day, associated with crampy abdominal pain and fatigue. On further questioning, the patient reported having repeated attacks of red eye and painful oral ulcers, partially responding to topical treatments. This was also associated with low back pain, increasing by rest and relieved by motion of 5 months duration. At that time, the patient sought medical advice at another hospital, and her labs then revealed elevated ESR and CRP and microcytic hypochromic anemia. Stool analysis was negative. Clostridium difficile toxin assay was negative. Fecal calprotectin was 170, and she had normal pelvic abdominal ultrasound. The patient underwent colonoscopy, which revealed diffuse, scattered, rounded, superficial ulcerations in the terminal ileum. And the terminal ileal biopsy revealed neutrophilic cell infiltrates with normal creep pattern and no granulomas. The patient underwent MR intrography, which revealed neural thickening of terminal ileum with post-contrast neural enhancement, denoting inflammatory process. There was no fat smudging or enlarged lymph nodes, and there was no evidence of adhesions, strictures, fistulae, or abscesses. The patient was then diagnosed as Crohn's disease and was kept on prednisolone with good improvement of bowel motions. She had frequent relapses since then, but this improved with adding azathioprine and mesalamine. However, the patient recently presented to our ER. She had suffered from an attack of generalized tonic-clonic convulsions on the previous day, and the neurological team recommended brain MRI, which showed transverse sinus thrombosis with multiple hemorrhagic venous infarctions. A more thorough history revealed that the patient had left-sided acute non-provoked DVT 1 year ago and was kept on oral anticoagulants, which she stopped by herself 3 months later when she improved. The assessment of on examination of the patient in our ER, the patient was vitally stable. She was slightly pale. She had mild tenderness in the right iliac fossa, and a healed genital ulcer was noted. Fundus examination revealed the picture of panuveitis with retinal vasculitis. This constellation of multisystemic neurological, rheumatological, gastrointestinal, vascular, and ophthalmological symptoms, together with endoscopic and histological findings, suggested intestinal Behçet disease. Behçet disease and Crohn's disease are considered two sides of the same coin, sharing many clinical and demographic parameters in addition to some management protocols. However, each disease has its own set of unique characteristics, differentiating it from the other one. The patient was admitted to intensive care unit with a multidisciplinary team involvement, including neurologists, rheumatologists, and gastroenterologists. She received pulse steroids and induction course of cyclophosphamide. The patient's condition improved, and she was later discharged for regular outpatient follow-up and maintenance therapy. Our main take-home message: in patients presenting with combined systemic and gastrointestinal manifestations that are atypical for inflammatory bowel disease, especially Crohn's disease, it is necessary to revise the diagnosis and consider other IBD mimics, among which is intestinal Behçet disease. Thank you.
شكرا يا احمد. يعني الحقيقه الكونكلوجن هي دي كونكلوجن يعني موافق عليه. We have to revise our concept of diagnosis of Crohn's disease لان احنا دلوقتي عايشين في هوجه اسمها Crohn's disease. اي عيان عنده abdominal pain يبقى Crohn's disease بالرغم ان مفيش كرايتيريا بتقول كده. شكرا يا احمد.
Next speaker will be Dr. Ahmed Sabha.
دكتور احمد الصباغ. اتفضل يا احمد.
Our patient here is a 56-year-old gentleman presented to our team by cirrhosis due to autoimmune hepatitis overlapping with primary biliary cholangitis. At the time of transplantation, child score was B9 and his MELD was 15 and received special score because of intractable ascites. Before transplantation, his laboratory workup showed positive lupus anticoagulant and positive anticardiolipin antibodies. His donor was 32-year-old unrelated gentleman with no medical or surgical history. His transplantation pathology showed that confirmed our diagnosis before the transplantation. 2 days after the transplantation procedure, the patient started to develop progressive increase in bilirubin level, heroic from 8 to 10 to 18, and INR gradually increased 1.2 to 2.4, 2.7, with decreasing factor 5 to 30% and gradually progressive hepatic encephalopathy. Imaging showed hepatic infarction distributed along the vasculature lines, and this is the infarction site. The first diagnosis to come to mind in this case that we have hepatic artery thrombosis, portal vein thrombosis, or venous outflow obstruction, and the picture of the hepatic encephalopathy, the failed liver, and the radiological diagnosis necessitated the decision of retransplantation. But the problem came that despite multiple Doppler imaging, all the vessels were open. We have patent hepatic artery, normal resistance index, patent hepatic portal vein, normal peak systolic velocity, and triphasic wave pattern in the hepatic veins. So we have to search for another diagnosis. The other diagnosis was antibody-mediated rejection or autoimmune vasculitis causing the segmental distribution of the infarction. So we sought to do a HLA cross-matching after the failed liver before the retransplantation procedure. It shows a positive reaction in 66% of class 1 antigen and 14% of class 2 antigen. So the diagnosis of antibody-mediated rejection was confirmed. Unfortunately, the patient graft was failing already, so we proceeded to retransplantation. This is the report of the HLA matching. After retransplantation, the patient developed again elevated bilirubin level 13 to 15, but at this point we were ready with the rituximab and plasmapheresis and IVIG. The patient received 3 doses of rituximab and 3 cycles of plasmapheresis and IVIG, each cycle consistent of 6 doses. And this is the allograft from the explanted liver. It shows focal faint staining of the CD4 cells and CD20. There was no active cells, which confirms the diagnosis of antibody-mediated rejection. After receiving the rituximab, plasmapheresis, and IVIG, the patient profile completely normalized. His bilirubin decreased to 2, AST/ALT normalized, INR dropped to 1.2, which confirmed the diagnosis and the treatment. The take-home message that antibody-mediated rejection liver transplantation is a field in its infancy compared to its allograft cohorts like kidney transplant. Acute antibody-mediated rejection is diagnosed based on specific and histologic criteria: serum donor-specific antibody, CD4 staining, histopathological finding on liver biopsy, and exclusion of other entity. Thank you.
Next presenter will be Dr. Hiba Hassan, Assistant Lecturer of Ain Shams University.
المفروض ان احنا هنختار من بين البرزنتيشن احسن 3 برزنتيشن هياخدوا جوائز، واحنا طبعا بنشكر شركه سبيماكو الدكتور احمد زغلول الحقيقه for supporting this session، والحقيقه هي يونيك سيشن الحقيقه في المؤتمر allowing the junior staff to present their experience. بنشكر سبيماكو تاني والدكتور احمد زغلول. اتفضلي يا دكتور هبه.
My case today will be a female patient, 49 years old, came to our ER complaining of severe abdominal pain, generalized, bloody diarrhea, more than 10 motions, and microstatic hyperchromic anemia. Patient stated that he was diagnosed 10 years ago ulcerative colitis and kept from pentasa to gram per day. Her last colonoscopy was 2 years ago, which is reported left colitis. Patient admitted and treated as a acute severe case of ulcerative colitis. A detailed history has been taken from the patient, which result patient has a history of superior vena cava thrombosis and residual dilated upper chest wall veins, history of recurrent non-tender genital lesions, and sometimes attack of oral ulcers. Patient has given IV steroids with good clinical responses. Her labs shows total leukocytic count was 5, her hemoglobin is 5.2, and platelets was 223. Kidney functions were normal, liver functions normal, virology normal, ESR was 30, TRP 50, and stool analysis, YPCs was 10 to 20, and RPCs over 100. So we considered to reassess the case. Her physiology test was negative, fundus examination showed hypertensive retinopathy, ANCA-C positive, and other autoimmune markers all are negative. As regarded colonoscopy, and here is the transition of our case, it showed only scattered ulceration in the sigmoid colon. So we start to think about our diagnosis of the patient. It had been falsely diagnosed 10 years ago as an ulcerative colitis and treated as words. So we decided to do CT pelvic abdomen of the patient, which showed our surprising findings. The root of the mesentery at the level of the inferior mesenteric artery showed perivascular soft tissue lesions, and these lesions is affecting the sigmoid, or the whole course of the sigmoid colon, causing thickening irregular wall. Here is the inferior mesenteric artery and the perivascular soft tissues. And here is the inferior mesenteric artery branches and the perivascular soft tissues around it. As regard the report of the CT pelvic abdomen, the diagnosis sclerosing mesenteritis with associated attenuation of the vasa recta with subsequent ischemic colitis. Further workup was sent to the patient. IgG4 was normal, CK total was normal, and tuber marker was normal, and the patient diagnosed as idiopathic sclerosing mesenteritis. Patient had received the induction by steroids and been told by ASA, and she now is good and well. Thank you.
Thank you, Dr. Heba, for this interesting presentation. Then we'll move to Cairo University.
الدكتورة هادي أيمن موجودة، اتفضلي. أول حاجة.
Thank you, Mr. Chairman. First of all, I would like to thank my dearest professor, Dr. Zakaria, for his very kind invitation. And it's with my utmost pleasure, I will present now our Qasr Al-Aini group and team. And our first presentation will be presented by Dr. Salma Rai, Assistant Lecturer of Endemic Medicine, Cairo University. And she will now present a case titled Some Good News.
Thank you, Dr. Hadi. Thank you, dearest professors, and thank you, Professor Dr. Siraj Zakaria, for his kind invitation. It's a pleasure to be amongst you today. Now I'm going to start presenting the first case on behalf of my team. We're going to talk about a 36-year-old male patient. He's a heavy smoker with no past medical or surgical history. He came complaining of yellowish discoloration of the skin and the sclera of 2 months duration. The condition was started 2 months ago with jaundice of gradual onset and progressive course. It was associated with dark urine and normal color of the stools. It was also associated with generalized itching that showed no diurnal variation. And the patient also complained of fever, which was more at night. There were also dull aching right hypochondrial pain, vomiting, which occurred 3 to 4 hours after meals, and loss of appetite and loss of weight, about 30 kilograms in the past 2 months. The examination was unremarkable, apart from a tinge of yellowish discoloration of the sclera, low-grade fever, and abdominal tenderness. We came with a differential diagnosis for the jaundice, which was mainly medical. We thought of autoimmune etiology, infection, or drug-induced. We also thought of surgical causes like malignant obstruction or stones. The patient was admitted and we did the basic investigations. The CBC showed mild normocytic normochromic anemia and mild leukocytosis. ESR and CRP were elevated. Virology was negative. The biochemical profile showed total bilirubin 3 over direct 2, elevated ALT and AST, and mildly elevated alkaline phosphatase and gamma GT. The rest was normal. Kidney function and electrolytes were normal, and the pancreatic enzymes were mildly elevated, while tumor markers were normal. We did an abdominal ultrasound, which showed pancreatic head mass, which was 4 times 3 centimeters, solid hypoechoic heterogeneous lesion. We showed the porta hepatis lymphadenopathy, the largest lymph node measuring 1.6 centimeters, and dilated CBD, which showed the biliary obstruction at the level of the distal end of the CBD. This was the ultrasound picture. And then we did a CT abdomen, which showed a heterogeneous enhancing mass in the head of the pancreas, measuring 38 times 44 millimeters. It was seen non-separable from the pancreatic head. It also showed regional lymph nodes, which were probably neoplastic, according to the image. The largest measuring 18 times 14 millimeters, associated with a thick-walled enhancing CBD, around 14 millimeters. Conclusion was going towards extrahepatic biliary obstruction due to locally invased, probably neoplastic mass in the head in the pancreatic head for histopathological assessment. And this was the CT picture. We did an ERCP to relieve the obstruction. It showed the post-bulbar stenosis traversable by the scope. The CBD showed the stricture in the distal end, and the sphincterotomy was done, and the plastic stent was inserted. At this point, we were thinking of malignant obstructive jaundice. The patient was being prepared for metastatic workup and eventual surgery consultation for removal of the tumor. But then we did an EUS beforehand to take a biopsy. The EUS showed an amalgamated porta hepatis lymph nodes forming a mass lesion measuring 30 times 30 millimeters, and a fine needle aspiration was done. It also showed a deformed thyroid ring, not allowing the passage of the scope, and an improperly visualized pancreatic head. Now, the surprise was in the results of the biopsy, which showed tuberculoid granulomatous lesion, most likely tuberculosis. Of course, the diagnosis of tuberculosis was confirmed, and anti-tuberculous drugs were initiated with close monitoring of the liver functions. And in the follow-up, the patient showed the tremendous improvement. Jaundice resolved completely, and the patient became afebrile. His appetite improved, and he put on weight. He gained around 10 kilograms in 1 month. The labs before and after treatment showed also tremendous improvement. bilirubin normalized, and the liver functions. And the follow-up ultrasound showed the disappearance of the head mass that was showing before, and no detectable pancreatic lymph nodes, and the CBD collapsed over the stent. Thank you so much. And now I'm going to...
Thank you so much, Dr. Salma Rai, for this very interesting presentation and some good news. Now, our next presenter is Dr. Salma Amran, Assistant Lecturer of Endemic Medicine, Cairo University, and she will present a case titled "It's in the Blood."
Thank you all, and I would like to thank dear Professor Dr. Sarag for his kind invitation. I would like to present this case of a 31-year-old lady presented to our department by 1-month history of gradual onset progressive cause jaundice with clay-colored stool and dark-colored urine and pruritus, associated with epigastric pain related to the back, significant weight loss, fever with no diurnal variation, no chills or rigors or excessive sweating, and later on she developed recurrent attack of vomiting containing food particles, and she denied any other symptoms with free medical and surgical history. The examination showed jaundice, fever, scratch marks, and epigastric tenderness. The differential diagnosis here is for cholestatic jaundice, whether extrahepatic causes or intrahepatic causes. Our initial investigation showed moderate normocytic normochromic anemia, hemoglobin 9.6. The liver biochemical profile showed hyperbilirubinemia, mainly direct, with cholestatic hepatitis and elevated LDH and beta-2 microglobulin, otherwise normal laboratory results. The point of care ultrasound showed biliary obstruction at the distal end of CBD for ERSP, with large solid hypoechoic pancreatic mass measuring 4.5 by 5 centimeter with dilated pancreatic duct, multiple hepatoduodenal portahepatis lymphadenopathy, echogenic rounded, the largest measures 2.2 by 2 centimeter, and diffused wall thickening of the antrum of the stomach with dilated proximal part for upper endoscopy and mild pelvic ascites. The CT abdomen with IV oral contrast confirmed the same findings seen by the ultrasound. The red arrow showed the gastric thickening and the white arrow showed the pancreatic head mass. The ERSP was done with CBD cannulation, show marked distal CBD structure with intrahepatic periradical dilatation and stent insertion with good biliary drainage, and normalization of bilirubin was achieved within days post-ERSP. The upper endoscopy showed gastric submucosal mass extending from the cardia to the greater curvature with the hyperemic overlying mucosa, in addition to duodenal submucosal mass, both were biopsied. The EUS here show the large pancreatic mass with mostly benign malignant nature and hard on elastography encasing superior mesenteric artery and splenic portal junction confluence with multiple peripancreatic lymph node. The stage was T3N1, EUS FNA was done. The histopathology of the previous 3 biopsies were the duodenal with mild chronic active duodenitis, the gastric biopsy with minimally represented atypical round cell infiltrate for immunophenotyping, which advised for a deeper biopsy, the pancreatic head mass with atypical ductal cell, highly suspicious of adenocarcinoma with moderate anaplasia. The EUS guided biopsy, the repetition from the posterior wall of the fundus was done, and there were asymmetrical thickening of the fundus of the stomach, measuring 2.5 centimeter. The histopathology of the gastric biopsy was undifferentiated small cells for immunophenotyping that then showed a benign origin. She developed fever, recurrence of obstructive jaundice, repeated attacks of vomiting, and hypovolemia during the hospital stay, upon which she was admitted to the ICU for stabilization of her condition. The follow-up ultrasound showed the same features of biliary obstruction, and the splenomegaly, and the gastric cavity was seen dilated down to the suprapubic region with gastric outlet obstruction. And surprisingly, the CBC on this occasion with fever showed a plot cells 20%. The bone marrow aspirate was done showing infiltration by 82% heterogeneous plot cells with picture of acute leukemia. The immunophenotyping and flow cytometry show a picture of acute B-cell lymphoplastic leukemia, and the Philadelphia chromosome translocation was negative. And she was transferred to the oncology department and received the chemotherapy with achievement of complete remission and follow-up ultrasound 3 months later revealed no abnormalities with complete resolution of the pancreatic mass, gastric wall thickening, and intra-abdominal lymphadenopathy. This is a case report. There are multiple case reports presenting with having the same presentation with acute lymphoblastic leukemia with pancreatic involvement, mimic pancreatic tumor. The take-home message from this presentation and the one before, the pancreatic masses are not always due to pancreatic adenocarcinoma. Other causes should be considered, especially in cases with atypical presentation, and thorough investigations are required before management, like here, and the previous case was EUS FNA. Thank you.
Thank you so much, Dr. Salma Amran, for this fascinating case. And the lesson we learned from the previous two cases was that in the young age group particularly, we should consider always the mimics of adenocarcinoma in cases presenting with pancreatic head masses. And it also highlights the importance of EUS and EUS-guided biopsy before treating and managing pancreatic head tumors. Our next case will be presented by Dr. Ahmed Ali Musad, Assistant Lecturer of Endemic Medicine, Cairo University, and his case is titled "The Skin Reveals."
Thank you, Mr. Chairman. I would like to thank my dear Professor Sirag, for his kind invitation. Allow me to present my case. A 40-year-old male patient with no previous medical or surgical history, heavy smoker. He came complaining of recurrent attacks of abdominal pain. The condition started 2 months ago by recurrent attacks of periumbilical colic abdominal pain that was aggravated by meals and improved by fasting. He did not report any nausea, vomiting, or a change in his bowel habits. 3 weeks later, he developed a more severe colicky pain that was associated with vomiting, absolute constipation, and abdominal distension, with a provisional diagnosis of intestinal obstruction for which surgical expectoration was done. Surgical expectoration revealed inflamed bowel loops from the distal jejunum to the cecum. The patient was discharged to the ward and received antibiotics. 2 days later, he developed bilateral lower limb erythematous skin rash. It was maculopapular and non-itchy. The rash lasted for 1 week and disappeared without any specific treatment. However, he continued to experience similar attacks of pain, but with less severity. Throughout these 2 months, he lost 2 kilograms of his body weight. Rash reappeared 1 week before admission to our ward. No history of fever or perception of body masses, no history of arthralgia, arthritis, oral or genital ulcers. On examination, there was a pallor skin rash affecting both upper and lower limbs. It was erythematous and maculopapular and lower limb edema. Midline scar from the exploratory surgery was there. All other system examination was free. These are the pictures of the rash. Our differential diagnosis at that point was inflammatory bowel disease, specifically Crohn's disease, eosinophilic gastroenteritis, or autoinflammatory disorders like FMF, and vascular causes that could mimic IBD, particularly small, large, and medium vessel vasculitis and Behçet syndrome, and ischemic colitis. On pelvic abdominal ultrasound at our ward was done and revealed bowel wall thickening and segmental dilatation and right colonic dilatation. Edema of the mucosal fold suggestive of venous congestion. Picture is suggestive of vasculitic etiology of the bowel disease owing to the intestinal pseudo obstruction, bilateral renal parenchymal disease, and mild ascites. Urine analysis revealed microscopic hematuria, hyaline casts, and heavy range proteinuria ranging 3 grams per 24 hours. CBC revealed mild acidic normochromic anemia, elevated inflammatory markers ESR 85 and CRP 33.9. Chemical profile was normal apart from mild hypoalbuminemia. Virology was negative, thyroid profile was normal, autoimmune profile was essentially normal, C3 and C4 were not consumed. Multi-slice CT mesenteric angiography showed no significant stenotic or obstructive lesions of the mesenteric vessels, patent distal aorta with no significant stenotic lesion, mural thrombi or aneurysmal dilatation. Colonoscopy revealed multiple deep variable sized ulcers affecting the descending and sigmoid colon and terminal ileal hyperemia. And these are the colonoscopy pictures. Pathology report from the colonoscopic samples revealed non-specific ileitis and non-specific colitis, with focal non-specific minimal ulceration. A skin biopsy was done, and its histopathological features were consistent with leukocytoclastic vasculitis, a small vessel vasculitis. Rheumatology consultation was done, and the most probable diagnosis is IgA vasculitis, formerly Henoch-Schönlein purpura, and they recommended doing a renal biopsy and immunofluorescence. Renal biopsy was compatible with a healing stage of focal proliferative glomerulonephritis with secondary SGS. The patient was then discharged on prednisolone 25 milligrams per day, and Celcept was added from 2 grams per day that was titrated as per rheumatological recommendation to 3 grams per day, owing to the renal involvement of the case. He was scheduled for regular follow-up visits at our department on a weekly basis. 2 weeks after discharge, the patient showed marvelous improvement regarding his clinical and lab abnormalities. Clinically, he was afebrile, abdominal pain dramatically improved, lower limb edema and skin rash completely resolved, and he started to regain his original body weight. Labs, his proteinuria improved from 3 grams per day to 300 milligrams per day. CBC parameters are stable despite Celcept therapy, and his inflammatory markers markedly improved. Our take-home message: medicine is a science of uncertainty and an art of probability, and when it comes to acute abdominal pain, which poses a great uncertainty, multi-system involvement and systemic inflammation together with continuous abdominal pain should warrant a further evaluation for a multi-system affection like vasculitis. Thank you.
Thank you so much, Dr. Ahmed Ali, for this intriguing case. And indeed, our take-home message is that we should always follow every clue in our patient, and we should always opt for a multidisciplinary approach. Our next case will be presented by Dr. Iman Bassel, an assistant lecturer of Endemic Medicine, Cairo University, and her case is titled Diagnosis in Disguise.
Thank you, Mr. Chairperson. I'd like to thank Professor Dr. Siraj Zakaria for this kind invitation. My dear professors and colleagues, I'd like to present a case of a 23-year-old male presented to the outpatient clinic with jaundice and bilateral lower limb edema of 2 weeks duration. The jaundice onset was gradual, associated with recurrent attacks of spontaneous epistaxis from both nostrils, but no bleeding from other body orifices. The jaundice was not associated with changing color of urine or stool, pruritus, fever, or abdominal pain. The condition was associated with mild tender right forearm and hand edema, limiting their movement without any color changes. The patient had generalized fatigue, bony aches, and anorexia. Upon careful history taking, the patient gave history of recurrent oral ulcers, patches of alopecia, as well as photophobia and repeated headaches. The patient gave history of oral bodybuilding formula intake for 2 years, but was discontinued 1 year before presentation. Clinical examination only added grade 1 clubbing of the fingers, pinpoint non-blanching erythematous papules on the anterior aspect of both legs, bilateral symmetrical ankle edema, non-pitting with non-tender, tender right hypochondrium and epigastrium, dull Trobe's area. The patient was admitted to investigate autoimmune disease with hepatic affection as the most probable diagnosis. Ophthalmological examination was done to reveal only bilateral grade 2 papilla edema. However, MRI and MRV were done to exclude CNS causes, and the results were free. ENT consultation for his epistaxis revealed ulcerations and macerations along the nasal septum and inferior turbinate. Right upper limb venous duplex on admission revealed no DVT. There was only chronic superficial thrombophlebitis on the lower 2/3 of the cephalic vein. X-ray of the hand and forearm were free. Abdominal ultrasound revealed mild fibrofatty hepatomegaly, mild splenomegaly, mild free intraperitoneal fluid, and mesenteric lymphadenopathy. Lab workup showed moderate normocytic normochromic anemia, low albumin and total proteins, hyperbilirubinemia, elevated ALT, alkaline phosphatase, gamma GT, elevated CRP, and markedly elevated ESR. Serology revealed the anti-smooth muscle antibody positive, ANA positive. However, the viral hepatitis markers were negative. During his hospital stay, the patient experienced colicky abdominal pain with recurrent vomiting for 24 hours. During this time, abdominal examination revealed an intra-abdominal tender fusiform mass in the right iliac fossa. Ultrasound on the right iliac fossa showed diffusely thickened terminal ileum with edematous mucosal folds, tender on probing. The proximal smooth bowel loops look dilated and hyperperistaltic, with the possibility of mesenteric venous occlusion. A second abdominal ultrasound added only innumerable tiny hypoechoic focal lesions in the spleen. Some are confluent near the lower pool of the spleen, having triangular shape, most probably infarctions. An ultrasound guided biopsy was taken from the liver as well as one of the mesenteric lymph nodes in the right iliac fossa and were sent to the pathology. While waiting for the pathology, the patient developed a painful edema in the right forearm and worsening of the right forearm edema, so a second upper limb venous duplex was done, revealing freshly formed thrombi in the right axillary vein, one of the left axillary vein branches, and one of the left brachial vein branches. The recent events pushed the probable diagnosis of vasculitis to the top of the differential diagnosis, with Behçet and Wagner granulomatosis disease competing for the final diagnosis. However, not all criteria fulfilling either diagnosis could be met. The surprise was in the biopsies. The liver biopsy showed mild venous outflow obstruction with no evidence of vasculitis. However, the mesenteric lymph nodes revealed dense atypical lymphoid infiltrate, likely reactive. Immunohistochemistry was recommended, which revealed large B-cell lymphoma of post-follicular center origin. The patient received chemotherapy with complete resolution of all of his symptoms, and he is now in complete remission. The take-home message is that paramalignant syndrome can mimic autoimmune disorders with even hepatic affection. Thank you.
Thank you so much, Dr. Iman. Very interesting case and for your take-home message. And now the last case will be presented by Dr. Rana Marwan, Assistant Lecturer of Endemic Medicine, Cairo University, and her case is titled "It's Never Too Rare."
Thank you, Prof. Dr. Sarag Zakaria, for your kind invitation. I would like to present my case. A male patient, 25 years old, who works at a blacksmith, comes with no special habits of medical importance, presented to our department complaining of severe right lower limb pain and limping of 3 months duration. His condition was associated with fever reaching 38 degrees Celsius, associated with rigors and sweating. He sought medical advice and did an MRI, which revealed the right iliopsoas abscess, for which he was transferred to our ultrasound unit for drainage. His examination showed right knee swelling causing limitation of movement of the right knee joint, and the palpable left inguinal lymph node rounded and about 2.5 centimeter in diameter. Otherwise, all other system examination was free. Our differential diagnosis for his iliopsoas abscess was TB plus or minus Pott's disease, secondary iliopsoas abscess to infection, genitourinary or musculoskeletal or GIT inflammation, or a primary iliopsoas abscess, which was a rare differential diagnosis as it's more common in children or immunocompromised patients. His investigations were all normal apart from elevated ESR. His tuberculin skin test was negative. The pelvic abdominal ultrasound revealed right iliacus muscle fluid collection measuring about 3.5 centimeter and 2 oblong hypoechoic para-aortic lymph nodes and a left inguinal lymph node measuring 5.3 centimeter. Ultrasound guided aspiration from the collection was done and sent for ADA culture and sensitivity. The ADA result was elevated while the measured culture was negative. A femoral lymph node biopsy was taken at this time, but it revealed only inflammatory infiltrates for further clinical correlation. Based on this clinical picture and the high ADA level, our patient was prescribed anti-tuberculous treatment for 9 months and was on regular follow-up. During his visits, the abscess was currently drained by ultrasound aspiration. However, the enlarged lymph nodes showed no improvement, and the patient kept complaining of the limping together with his right knee swelling. We thought furtherly it could be TB osteomyelitis or arthritis, and at this time, another biopsy was taken from the persistent left inguinal node. Meanwhile, his CT abdomen pelvis showed the persistence of the left inguinal lymph node, together with a review of the bone window, which was our clue. The bone window showed multiple sclerotic and lytic lesions within the vertebral bodies and abnormal bony expansion of the right iliac bone. So an MRI of the right knee joint was ordered. The femoral lymph node biopsy came to show diffuse infiltrates mostly by large lymphoid cells with scattered mitotic figures, a picture consistent with large cell lymphoma for immunophenotyping, which was positive for CD3 and CD20, and the patient was diagnosed as large B-cell lymphoma. Meanwhile, even his MRI of the right knee joint revealed a picture representing lymphoma of the bone, which was a very rare presentation. And here we show the right knee joint, which is infiltrated. The patient was referred to our oncology department and he started his chemotherapy sessions. He is now on regular follow-up with marked improvement. And here is a case report published in 2014 showing that the large B-cell lymphoma can really mimic the iliopsoas abscess following a proximal femur infection. Kindly, our take-home message was that the large B-cell lymphoma can mimic iliopsoas abscess, and although it's common in medicine, yet we have to give attention to the very rare presentations, and we shouldn't ignore the patient complaint. Thank you so much.
Thank you very much.
Thank you so
Thank
much,
you very much.
Doctor.
We'll call Dr. Maali Sawi from Egypt Air Hospital to call for two presenters from private sector hospital. تفضل دكتورة معالي.
Good morning. My deep gratitude, all my professor and the colleague. I will present my dear friend, Dr. Mohammed Magdi, to start the first case.
Dear chairpersons, our case today is a very small case. It's a male patient. Male patient, 40 years old, there is irrelevant past medical history. He was presented with severe abdominal pain, attacks of diarrhea with mucus, and sometimes bleeding rectum. The condition started 2 weeks ago. Investigations was done, revealed marked leukocytosis, with shift to left, pulse stool analysis revealed pus cells, RBCs, and excess mucus. And he sought medical advice and was diagnosed as acute gastroenteritis and received a short course of antibiotics with no improvement. A week later, the patient was presented by marked abdominal pain and distension with toxic manifestations. He did a CT that revealed mural thickening of the rectosigmoid part and also a picture highly suggestive of diverticulitis. He received medications and antibiotics with no improvement. The decision was to do a colonoscopy. In the colonoscopy here, the rectosigmoid angle, there was bleeding and was severely inflamed. The rectosigmoid. This was severely inflamed area. And also we see here lots of pus. Also in this picture. And the rest of the colon was free. So the decision was for the condition of the patient to refer him to surgery. And after exploration, the patient was diagnosed with perforated mucous diverticulum and complicated with ileoclonic fistula, which is a very rare complication of mucous diverticulum. This was the pathology of the patient. Thank you.
Case 2, male patient, 18 years old, came in motor car accident. After resuscitation, labs and radiological assessment revealed the intraperitoneal hemorrhage. Exploration was done and revealed liver repair was done and the backing with good hemostasis. The patient was getting better. 3 days later, he had an attack of melena. Upper endoscopy was done that revealed erosive pangastritis was and no stigma of recent hemorrhage. He received the proton pump inhibitor infusion and the melena stopped. He was shifted to oral PPI. The patient is about to be discharged. Then he developed severe attack of active hematemesis. His hemoglobin dropped to 5 grams percent. After resuscitation, upper endoscopy was done. This is the video. في الحقيقة أنا اللي عملت المنظار. العيان ده الأبر اندوسكوبي. أنا I insist إن أنا أدخل فيه في active bleeding خيفة يكون في عنده زي ديلافوي أو أي active blood vessel. طبعا يعني الموضوع ما كانش أفضل حال يعني. ده كان الأبر اندوسكوبي وكانت الاستومك full of blood. وما كانش فيه اي significant bleeding point. وما وصلت للسكند بارت في الحقيقه كنت شايفه فيه بلاد كتير جاي من السمول انتستين. دخلت بانتيروسكوبي وصلت تقريبا 2/3 من الجيجينم. برضو ستيل كان فيه بلاد كتير جدا جاي. كان في gush of blood جاي from everywhere. بعد الجاستريك ووش ما كانش فيه اي bleeding point او spurter يقول لي هو العيان فيه ايه. وكان العيان يعني almost بقى shocked. دخلت ب ERSP عشان اكسبلور البابيلا، especially هو كان عامل عنده ليفر تير ومعمول له باكينج، بس ما كانش فيه انترابريتونيال اي انترابريتونيال كولكشن يقول ان في مشكله سيرجيكال يعني. كانت البابيلا ما فيش اي بليدنج بوينت من ناحيتها. فكان الديسيجن السريع ان احنا we will call for interventional radiology، واللي ساعدنا فيها دكتور احمد حسني. ولقينا الليجن ده hepatic artery aneurysm. اتعمل له جيل فوم امبولايزيشن وإميديت البليدنج وقف والعيان بقى fully resuscitated وخرج بالسلامة. Take home message: select who will help you. Thank you very much.
Thank you very much. Actually, all the cases were very interesting, and I'm sure that all presenters did good work for preparation of the presentations.